Hello and welcome to class, all of you. Student, I hope I am audible to you. Just let me know whether I am audible and visible to you. I'm just waiting for your response. Audible and visible to you, I hope. Okay. Good morning to all of you. Okay, so basically we are going to discuss some of the clinical neurophysiology MCQ. As you know that this is part 2. I hope you must have forgot that I have taken also one part 1 and it is there in the Unacademy YouTube channel. It is still recorded there, so you can listen that. But now today we are going to discuss few more MCQs which are related to this clinical neurophysiology, which will help you understand the topic also, right? So directly, without any much talking, I am going to the MCQ directly. So this is the MCQ today, first MCQ in front of you today. Okay, so a medical student is studying the neurons that are part of a descending pain modulating system. This is one of the important hot favorite topic in NEET, descending pain modulating pathway. What brain region is correctly paired with the neurotransmitter it releases, and the location where the neurotransmitter is released. So basically the question is in a form of clinical based question, but ultimately you require the knowledge of physio to answer this question. So look at the options, read them carefully. I am giving you 1 minute to answer the question that what will be the correct answer, what you think that will be the correct answer here. Okay, so periaqueductal gray neuron releases endorphin in the spinal cord dorsal horn. Second, nucleus raphe magnus releases serotonin in the dorsal root ganglion. Okay, locus coeruleus neuron releases serotonin in the nucleus raphe magnus. Locus coeruleus neuron releases norepinephrine in the spinal cord dorsal horn neuron. Right, dorsal root ganglion. So look at the each and every word, because the answer is a little bit critical here. Okay, answer is a little bit critical here. So what do you think, Dr. Tapos and Dr. Roshan, Dr. Alien Insight, right? Okay, so what do you think, what may be the possible answer? So first of all, you have to understand that do you know that this periaqueductal gray matter neuron, they releases endorphin. Up to this level, this is correct. Okay, try to understand the topic. Okay, so up to this level, periaqueductal gray matter neuron releases endorphin. Up to this level, this is correct, but it does not releases endorphin in the spinal dorsal horn. So this part is not correct here. This part is not correct here. So this is not my answer. Getting my point? That's why I'm telling you that it's a critical MCQ. Then second, nucleus raphe magnus releases serotonin. बहुत बढ़िया. This is the correct statement. Nucleus raphe magnus releases serotonin, but it is not in the dorsal root ganglion. No. It's not in the dorsal root ganglion. It releases serotonin, but that serotonin releases at the level of spinal cord interneuron. Spinal cord interneuron. You will understand the whole topic, but look at what the statement is wrong. Locus coeruleus nucleus releases serotonin. Obviously, so this is the wrong one here. That locus coeruleus does not releases serotonin, but locus coeruleus releases what? Locus coeruleus releases norepinephrine. So this is also true. Up to this level is true. And in the spinal dorsal horn, yes. So this is the correct statement. So answer here will be D. answer here will be D, right? So look at what the thing that you have to remember. I will come back to this MCQ once again, okay, after discussing the topic, but look at the discussion first. Important, I am telling you for NEET exam. So first of all, you know that analgesic system, which are known as the endogenous analgesic system, okay, endogenous analgesic system are there inside our body. One of the endogenous analgesic system is the gate control theory, or the gate, which are present at the dorsal horn of the dorsal root of the spinal cord. Okay, you know the dorsal region of the spinal cord contains this gate. So what is that gate? You all know that this A delta and C fiber, they are the pain carrying fiber. They are making a synapse with a second order neuron of the pain. So this is my second order neuron. So this second order neuron will bring the sensation up to the level of the thalamus, and from the thalamus it will go to the level of the cortex. We know this thing. From the thalamus it is going to the level of the cortex, right? There is no big deal here. This is the pain pathway. Now all of you know that gate control theory means this second order neuron is inhibited by one interneuron here. This is known as the G neuron. G stands for gelatinosa neuron, substantia gelatinosa neuron, and this G neuron in turn is stimulated by large diameter A beta fiber. And A beta fiber is what? All of you know that A beta fiber is nothing but for the touch and pressure. So that's why you know that whenever there is some pain occurring in your body, in that area, if you give some kind of massaging, or if you give transcutaneous electrical nerve stimulation, all of them basically stimulate this A beta fiber. So whenever you are stimulating this A beta fiber, it is going to stimulate this G neuron, and G neuron in turn inhibiting the pain pathway. That means the gate is closed. So what I am learning here? I am learning here that if I stimulate this A beta fiber by massaging, or by transcutaneous electrical nerve stimulation, or application of some balm which apply some massages, okay, what will happen? I am selectively stimulating this A beta fiber, and A beta fiber, what it is doing? It is closing the gate. So it is closing the gate of pain pathway, and that's why it is known as the gate control pathway. But this is not the question in this topic here. What is the question? Apart from this discussion which we are doing at the level of spinal cord, right, there are some descending pain modulating system also, and this descending pain modulating system, it start from the level of periventricular region. So I am writing here, this is PV. Listen very carefully. So this is periventricular region. Apart from that, there is another region which is known as the periaqueductal gray matter region. Neuron from both of these location, okay, so periventricular region and periaqueductal gray matter region, both of these region, the neuron is connected with the certain nucleus. What are the nucleus? Two nucleus name I have to remember. So these are the nucleus, okay. One is the raphe nucleus, and one is the locus coeruleus nucleus. So one is the raphe nucleus and one is the locus coeruleus nucleus. So what is happening? This periaqueductal gray matter and periventricular neuron, they are releasing the neurotransmitter here. This neurotransmitter, could you answer? This is nothing but enkephalin. Getting my point? So these two neurons are releasing enkephalin. This enkephalin is acting on these two nucleus, and from these two nucleus we all know that this raphe nucleus, it is going to produce the serotonin. So it is the serotonin here, and this other neuron, that is the, I'm taking some color, that is the locus coeruleus, it is going to produce the norepinephrine. So it is going to produce the norepinephrine. Getting my point? Everybody following? So this is serotonin. I'm writing the full name, serotonin, right? Then what next? So all of them, this serotonin containing neuron and norepinephrine containing neuron, they are extending up to the level of the spinal cord, but they take help of one interneuron here again, and this interneuron inhibit this presynaptic neuron and postsynaptic neuron by releasing the neurotransmitter again. This is enkephalin. This is enkephalin. So look at this diagram again, once again. Okay, so what I told, so neuron from the periventricular region and the periaqueductal gray matter region, they are releasing the enkephalin. I must have to remember this. But this enkephalin is released at the level of certain nucleus. What are the nucleus? Raphe nucleus magnus and the locus coeruleus. So raphe nucleus neuron, when it is stimulated by this enkephalin, it is going to produce serotonin at the level of spinal cord, and the locus coeruleus nucleus is going to produce norepinephrine at the level of spinal cord. But they are not affecting this pain pathway directly. Rather, this serotonin and norepinephrine, again they are taking help of this, interneuron, and this interneuron is producing enkephalin, and this enkephalin is going to inhibit the pain pathway. This is again a MCQ, and this inhibition is in the presynaptic neuron also as well as postsynaptic neuron also. So please remember that the inhibition from the descending pathway both at the level of presynaptic as well as at the level of postsynaptic pathway. So here they are. Here look at the statement again. Okay, now I told you, look at the statement again. So periaqueductal gray matter. So first statement is the periaqueductal gray neuron releases endorphin, correct, but it is not in the dorsal horn. Then nucleus raphe magnus, they releases serotonin, but it is not in the dorsal root ganglion. No, it is at the level of spinal cord level on the interneuron. Then locus coeruleus neuron releases serotonin. No, false हो गया. Locus coeruleus is for norepinephrine, and last statement, locus coeruleus releases norepinephrine in the spinal dorsal horn. Yes, actually it is not in the dorsal horn. Actually most of the neuron releases neurotransmitter on the interneuron. That interneuron produces enkephalin, and enkephalin inhibit the pain pathway. This is the exact thing which is given in Genon and Guyton, right? So everybody this understood? Everybody just give me a thumbs up whether you understood this or not, then I will go to the second topic, second MCQ. This should be clear, okay, and important. Gate control theory and the descending pain modulating pathway, both are important, right? So Dr. Naman and Dr. Roshan, Siddharth, all of you, if you are there, just give me a nod whether you understood this or not. Okay, right. Thank you, Dr. Tushar, for your response. Now we are coming to the next question, right? Thank you, Roshan. Thank you, Tushar. Okay. So now second question. Okay. Now got it. Now second question. Look at this thing. So again, one of the important topic. A 40-year-old man loses his right hand in a farm accident, right? 4 years later, so after long period of 4 years, he had episodes of severe pain in the missing hand. So this is typical of the phantom limb pain sensation. Now a detailed PET scan study of his cerebral cortex might be expected to show. So what I have to concentrate here? I have to concentrate that which hand has been amputated. Right hand has been amputated. So if there is right hand is amputated, then the problem is going to happen in which hemisphere? You first think that, and then what will happen to that hemisphere? Okay, so look at the option A, B, C, D and try to guess your answer, that what will be the answer, right? Okay. Any guess? D. Okay, very good attempt, Siddharth. Okay, so expansion of the right hand area in the right primary hemisphere. So if I read the statement completely, then I can understand the first statement is not going to happen. Oh my god, very good my student, I am happy. Okay, expansion of the right hand area in the left primary somatosensory cortex. Again, this is a false. Somatosensory cortex is not going to expand. Okay. Then projection of fiber from neighboring sensory areas into the right hand area in the right primary somatosensory cortex, and projection of fiber from neighboring sensory area into the right hand area of left primary somatosensory cortex. Okay, so option A is not true. Option B, expansion of the right hand area, where when the right hand is not there, it is not going to expand. Hand is not there, na? So why the area is going to expand? So this is not true. Projection of fiber from neighboring sensory area into the right hand area of the right primary, again this is not true. So obviously all of you are 100% correct, that D is the answer. That's projection of fiber from neighboring sensory area into the right hand area of the left primary somatosensory cortex. So what happens? Two things I have to remember. Everything is written here, I have taken it from my book, but look at, try to understand. Suppose this is the cortex, somatosensory cortex in this person. So and this is the hand, right? So from this hand the fibers are coming, and suppose this is the area of the hand in the cortex. This is the area of the hand which is perceiving the sensation. Now whenever there is an amputation, right, so this hand fiber are not reaching to the level of cerebral cortex. So this is my hand area, but nearby area which is present here, suppose this is the area of the mouth, suppose this is the area of the leg, what this other two area will do, this other two area will take the region of this hand like this. Getting my point? So the mouth area was smaller, mouth area was not that much big, mouth area is only this much was the mouth area, okay, and this was the hand area. But because now the hand is amputated, what will happen? There is no stimulation to the area of this hand. So what will happen? What is the utility of that area? Don't keep that area. But what will happen? The mouth which is present nearby area, this nearby area will take over the hand area like this. So now this is the large area which is taken up by the nearby sensory cortex, that is nothing by mouth, or it may be leg. But because mouth is getting more sensory fiber, so there is more chances that mouth is going to take over this hand area. So getting my point? So this is known as the reorganization. Good morning. This is known as the reorganization at the level of cerebral cortex, and this reorganization is known as cortical plasticity. This is known as the plasticity. This is known as the cortical plasticity. Getting my point? Now please hold on. So what I told because this hand is amputated, because the hand is not there, okay, because this hand is not there, so fiber is not reaching to the cortex, that's why the nearby sensory area is taking over the hand area. But still the fiber which are present here, the fiber, now I am giving you a here. So suppose this is the amputation. So now if I stimulate this ending of the nerve fiber, if I stimulate the ending of this nerve fiber from this amputated hand, what I am telling, suppose there is amputation here, but the nerve fiber is still there. If I stimulate this nerve fiber here, right, so the sensation is going to the level of the brain, and it will be perceived by different brain area, but it will be perceived, and this perception will be felt at the level of receptor. This is known as law of projection. So the theory which is used to explain the phantom limb is known as the law of projection. But if I tell you what is happening at the level of cerebral cortex, that is known as the cortical plasticity. So what is law of projection? So if there is an amputation here, and if you stimulate this neuronal ending which are present here, what you are going to perceive? You are going to perceive as if the pain is coming from the dorsum of the hand. Why? Because what was the original location of the receptor? Originally the receptor was present at the level of dorsum of the hand. That means if you stimulate nerve fiber at any point, the sensation is going to perceive from the level of receptor. Sensation is going to perceive from the level of receptor. The sensation is going to project at the level of receptor. This is known as the law of projection. That's why whether you stimulate any pathway, so if you are stimulating here the nerve fiber ending which are present here, but the person is feeling as if the person is feeling the pain is coming from the dorsum of the hand, although the hand is not there, but the sensation is projected at the level of receptor. Brain will not be able to differentiate that where from the stimulation is coming. Brain will perceive as if the stimulation is coming from the receptor level. So two things. If the question is that phantom limb is explained by which of the following law, then your answer will be law of projection. That is, it is the sensation is always projected at the level of receptor, where is the location of the receptor. And second thing, if the thing is that phantom limb is due to which of the following, then your main answer will be cortical plasticity. Because of the cortical reorganization, the person is still feeling the sensation. So दोनों में से if both are there in the option, that cortical plasticity is also given in the option and law of projection is also given in the option, then more important is the cortical plasticity part. Okay, so this is the first thing. Second thing is that in case of animal experiment, suppose this is your cerebral cortex and suppose this is the hand area. Okay, so hand area is receiving the sensation from the periphery. So this is the hand area. Now this is seen in case of animal experiment. Suppose I have removed the area of the hand from this cortex. This is different. Hand is still there. Okay, so the neuron is still there projecting here, but what I have done, in an experimental animal, I have removed the brain area which is perceiving or which are receiving the sensation from hand. So what will happen? Now again the neuron will reorganize, but this reorganization will be like this. The neuron will go back, the neuron will rearrange to a different area. The neurons is rearranging to a different area because this area of the hand has been removed. Okay, so what is happening? Because the area of the hand is removed, now the sensation of the hand will be perceived by different brain area because this hand area has been removed. So that's it, two things. If the hand is removed, then the nearby area is going to encroach upon this hand area. But if the area at the cerebral cortex is removed, then this area is not there. So the side by the neuron will be projecting to the side by area. So this is exact the thing what is written here. Okay, this is the exact thing what is written in this above discussion. The numeral animal studies dramatical organization of the cerebral cortex, that is plasticity. Here that if a digit is amputated in a monkey, so here the hand is amputated, the digit is amputated, what is happened? The cortical representation of the neighboring digit spread into the cortical area. So from the neighboring area it is encroaching upon. But conversely, if the cortical area of the digit is removed, so cortical area is removed here, so here the cortical area is removed, then what will happen? The somatosensory map of the digit move to the surrounding cortex. This kind of reorganization is known as cortical plasticity. Right? So this is one of the experiment which I have taken from one of the neurophysiology textbook. So what they are doing here in this experiment, look at here. So this is the normal person, this is from the normal person, and this is from a phantom limb person. So in this normal person, the hand is obviously intact, and here the hand is amputated. In this person, right? So what is happening? Look at the brain area. So this is the area of the mouth. Okay, smaller area. But in case of person where the hand is amputated, the hand area has been taken up by this mouth area. So the hand area has been taken up by the mouth area. That's why now they are doing the experiment and they are doing the fMRI study, functional MRI study they are doing. Okay, so what they are finding out, that if you give a tusk, that is the lip pursuing tusk, they have asked the subject, both this normal subject and this amputated person, to do a lip pursuing tusk like this. So whenever the person is doing some task on this lip, okay, so there is mouth area is activated. So mouth area activated means where you are going to get this blood flow increment. So this is the area where you are getting higher activity, But look at the area in case of phantom limb. So this is the area, it is activated obviously, but apart from that, this is the area which has been amputated. Now this is also activated because now this mouth area has extended to the hand area, and this is nothing but reorganization of the cerebral cortex, and this is nothing but known as plasticity. Right? So I hope all of you understood this basic thing, that what is happening at the level of brain and what is known as the plasticity, and I have written certain information about the phantom limb pain. So you can go through this point, that between 50 to 80% of the amputee experience this phantom limb pain. Okay, apart from phantom limb pain, there is phantom tooth pain also, there is phantom eye syndrome also, and this phantom limb pain is mainly due to cortical reorganization, which is known as the plasticity. Correct? Everybody just told me whether you understood this thing or not. Tell me whether you understood this or not. Okay, very good. Okay, so two things you have to remember, that if you remove the cortex, so nearby cortex is the cortex will be shifted to the nearby area, and if you remove the hand, the hand area will be encroached by the other cortical area. That is known as the organization of the level of cerebral cortex, and that is nothing but plasticity. Right? So this is important. So if the question is phantom limb pain is due to, your main answer is, don't forget this, the main answer is cortical plasticity. Your main answer is cortical plasticity, although it is also explained with the help of law of projection. Okay, so this is important for your NEET examination. Right? Chalo, next question. Now next question, easier question. So I know all of you will be able to answer. Read the question and try to answer it correctly. Okay. So EEG was recorded as part of class demonstration on a healthy 23-year-old male medical student. This is done in everywhere. Okay, that medical student do volunteer for their own practicals. Okay, an electrode was placed over his occipital lobe, and the activity was recorded initially while the person is awake, sitting restfully with eye closed, and then after opening his eye and he is alert. Okay, so first he is awake and restful and eye closed. Okay, and second is the opening his eye and he is alert. Now tell me, what is the sequence of wave that you are going to get? Easy question, I know. You will answer, I'm 100% sure. Go on. Dr. Dipesh, very good. Dr. Siddharth, good attempt. All of you want to answer now? Siddharth, Yejdani, Dr. Tushar, Avirup, Alien, try to answer. So when the person is awake but his mind is rest, he is taking rest, he is completely in restful condition. Yes, so what wave you are going to get? You are going to get the alpha wave. Okay, and when the person is opening his eye and he is alert, so this alert is more important, then you are going to get the beta rhythm. So here this is simple question, the answer is C. Okay, so now quickly revision. So we know that BAT dance, we remember like this. So this is the mnemonics for this BAT dance. So look at like this, try to remember like this, that suppose in one day, no idea about EEG. So look at, so EEG consists of various waves. So these are the four main waves. That is seen in the EEG, although there are other wave also. So this is the beta wave. Okay, this is the alpha wave, this is the theta wave, and this is the delta wave. Right? So how to remember? Suppose in one day you have planned to read all of the memory from the physiology, basis of memory. So that's a very difficult topic. we also do not know a lot about memory. So you have started that today morning I am going to finish the whole of the memory. So you are sitting in a chair like me and you are started reading Genong. Okay, so whenever you are doing this, your eyes are open, you are hugely concentrating on this Genong, that I have to understand whole memory chapter today. So your brain is highly active, your brain is highly alert, and your eyes are open. Again I am saying eyes open is not essential. Okay, drink blood at night, bad, anything, okay, anything, bad dance or drink blood or anything, whatever way you remember. There are multiple mnemonics, I know, but this is the simple thing. Bad dance is important. So whatever. So whenever you are awake, you are concentrating on something and your eyes are open, that wave you are going to get is the beta wave. Okay, so beta wave will be converted to alpha wave whenever you are trying to read Genong with higher concentration. After certain point of time, you forgot that you have planned today for Genong revision, because it is very boring. You are not understanding anything. So what will you do? Whenever you are not understanding anything, you will shut down your eyes, or maybe you are not shutting down your eyes, but your mind start wandering here and there. Forget about this study, forget about this memory. Think whatever you will do after the NEET is over, whatever you are going to do, whether you will go for a movie or not, and if the COVID situation is gone, then what will you plan for with the friend. So whenever you are doing this kind of thing, now your mind is start wandering here and there. Okay, whenever your mind is starting wandering here and there, that means you are relaxed, and in this condition the beta wave will be converted into alpha wave, right? And from there, okay, now you have started planning so long. For the last 1 hour you are planning that what will you do in after certain point of time. You are going to enter into a light stage of sleep. Whenever you are entering into light stage of sleep, okay, you are feeling drowsy, you are entering into the light stage of sleep, then the alpha wave will be converted into theta wave. And if you enter into the deep sleep stage, then you are going to get this delta wave. That's why I remember like this always, that I am highly active, I am trying to concentrate something, beta. Now I am relaxed, my mind is wandering here and there, that is alpha. Then alpha will be converted to theta when I am entering into the sleep, I am in a drowsy state, and the theta will be converted to delta whenever you are in a deep sleep stage, right? So this is the way we have to remember. How to identify this wave? You know the frequency, you must have to remember the frequency and count the frequency within this 1 second. Like for example, within this 1 second period, if I count the frequency here, I am getting that this is one wave, this is second wave, and this is third wave. So basically this is 3 hertz. Okay, 3 hertz, that is the 3 per second, 3 cycles per second. So this is nothing but is my delta wave. That way you have to remember the beta wave frequency 14 to 30. Then you have to remember the alpha wave frequency also, theta wave and delta wave frequency also. So that is a separate topic. You remember the frequency also. From the frequency you can identify the wave also, right? But the question which has been given here, that initially the subject was awake and he was in restful condition and his eyes was closed. Eyes closed. Restful is more important in this topic. Restful is more important. So whenever the person brain is resting, okay, remember the alpha wave is there and the person is awake. Okay, this is the typical phenomena. Which is known as alpha block. This is the typical phenomena which is known as alpha block phenomena. Important for your MCQ. So try to look at. So what I told, the student is awake. And he is in a resting condition. So awake and the student mind is in a restful condition. What wave we are going to get? Alpha wave. Look at the alpha wave. The frequency is slower and the amplitude is more. Okay, amplitude is more. Now whenever the subject is opening his eye, okay, what kind of opening? So just imagine yourself that you have closed your eyes and your mind is wandering and you are in a relaxed state. Suddenly I have given some sensory stimulation like this. Sensory stimulation like this. What will happen? Suddenly you are opening your eyes. Oh my god, what happens? So whenever you are opening your eyes, along with your brain is concentrating on something like this, what is happening? Then you are alert. You are alert. And whenever the person become alert, what is going to happen? Whenever the person become alert, whenever is going to happen, this alpha wave is converted into this beta wave. So this typical phenomena that alpha wave is converted into beta wave in presence of sensory stimulation, this phenomena is known as alpha block phenomena. Alpha block phenomena. Alpha wave is blocked and it is converted into beta wave in presence of sensory stimulation, like for example sound, light. So these are the sensory stimulation. In presence of sensory stimulation, whenever you are opening your eyes and your mind is concentrating on something, that what is going on, that is nothing but the typical beta wave, right? And again, whenever you are closing your eyes and you start thinking, your mind start wandering here and there, then again you are getting the alpha wave, right? So from this discussion, you have to remember one understanding. What is the understanding? The frequency of the EEG, most important thing, the frequency of the EEG is directly proportionate to the brain activity. The frequency of the EEG is directly proportionate to the brain activity. Increase in frequency will be seen whenever your brain activity is higher, and whenever your brain is less active, your frequency will decrease. That's why we have seen here that the highest frequency wave we are getting here in the beta, right? Although there are other waves also, but here it is beta. Then the frequency is decreasing. That means here your brain is getting more and more inactive. Brain is getting more and more inactive. More the activity, more will be the frequency. More the activity, more will be the frequency. I am repeating this again and again because this is the understanding which you must have to remember. Okay, now look at here. That's why whenever the person is given surgical anesthesia, obviously what kind of wave you are going to get? You are going to get the delta wave. Whenever the person is in deep sleep, what kind of wave you are going to get? That is nothing but the delta wave. So this is the wave. Look at the frequency, very slow wave, very slow wave. So if I look at here, that I am finding out that this surgical anesthesia and this sleep, they are the delta wave. Then various psychomotor activity. Okay, various psychomotor activity, you know that psychomotor activity, they are going to produce the theta wave. So these are the theta wave here, theta wave. Okay, the person brain is getting more active. Then when the person is doing the relaxation, right, then you are going to get the alpha wave. And then when the person is putting some attention onto something, then you are going to get the beta wave. And I know, and you also know, that during the tonic-clonic epilepsy or the first component of the absent seizure, they produced huge frequency wave, because at this kind of activity the brain activity is very high. So that means when the seizure is going on, when the epilepsy is going on, the brain activity is very high, and this huge activity means the frequency of the wave is very maximum. So normal physiological wave, what are they? This is the beta wave, high frequency, alpha, lesser frequency, theta, more lesser frequency, delta, more lesser frequency. But this delta wave can also be seen during surgical anesthesia. Theta wave can also be seen during various psychomotor disorder. Alpha wave can be seen when the person is completely relaxed or deteriorated epilepsy, or when the person is putting some attention, you are going to get the beta wave. So these are the various waves in brief in EEG. So this is the only thing which I can teach you in this short session. Otherwise EEG is a long topic. All of you know that EEG is a long topic. So I hope whatever I told you so far, you have understood this thing. So just give me a thumbs up whether you understood this or not. Understood? Okay? Everybody? Now if you have any queries now, you can ask here or you can contact me later on also. I'll be happy to assist you. Okay? bat drink blood at night. Dipesh, ठीक है, right? Okay. Alien Insider given nod. Roshan has also given nod. Thank you. Spindle, that's why I'm saying now that whole EEG I cannot finish, because whole EEG will take 1 hour. Okay, that spindle, K spindle and the sleep spindle, K complex, they are the stage 2 of the non-REM sleep. Okay, so we are not going to detail into that, but read that thing, and if possible I'll try to take another session on Unacademy Learner platform, because this whole EEG, if you want to discuss the sleep then the whole EEG will be discussed along with that, but it will take 1 hour, which is not possible in this short session, right? Okay, so now coming to this question, I have given answer to the other question. See, now coming to this question. Okay, so here one 35-year-old man reported frequent episode of sleepwalking, non-REM. I'm coming there. I have kept one slide. I know you are going to ask me. Okay, so I know. Sujit Kumar, just wait a little bit. I'll show you. Just it is related to this discussion only. So now try to answer this question. 35-year-old man reported frequent episode of daytime sleepiness. So this is a kind of suspected obstructive sleep apnea, and EEG was recorded, and it is saying that 30%, greater than 30% is the non-REM sleep. Well and good. Now what neurochemical changes in the brain trigger the transition from wakefulness to non-REM sleep? This is the question. Wakefulness to non-REM sleep. Okay, wakefulness to non-REM sleep. What is the changes that occurs? Try to answer here. So a decrease in norepinephrine and serotonin release to increase thalamocortical activity, then an increase in histamine release and a decrease in GABA release, an increase in GABA and melatonin, and an increase in GABA release and decrease in histamine release. Tell me what is the answer, correct answer. Look at the option. Yes? Anybody? Answer. So an increase in GABA and melatonin, right? A decrease in norepinephrine and serotonin release to increase thalamocortical activity. Okay. Anything else? Anybody want to try more? So I'm coming back here, but answer is neither A, neither B, neither C. Okay, so look at here. First thing, you know that hypothalamus is the main area which control your sleep. Hypothalamus is the main area which control your sleep. There is one posterior hypothalamus which is responsible for wake promotion. So that's why the posterior hypothalamus is known as the wake promoting area. So this is posterior hypothalamus, wake promoting area. Anterior hypothalamus, sleep promoting area. Now posterior hypothalamus, how it maintain the wakefulness? Try to understand like this, that posterior hypothalamus, how it is maintain the wakefulness of the person. It is connected with two area, locus coeruleus and raphe nucleus. Just now today we have discussed that raphe nucleus is going to produce your serotonin, and this locus coeruleus is going to produce your norepinephrine, right? So these two neurotransmitters, they are not responsible for sleep induction. They are responsible for stimulating the thalamus. So please remember, this norepinephrine and serotonin, although they are responsible for the pain decrease in pain sensation, okay, because they act on the enkephalin producing neuron, but here at the level of thalamus they are activating the thalamus, and because of the activation of the thalamus, what will happen? All the projection from thalamus is going to causes activation of the cerebral cortex, and the person remain in a awake state. So what is happening when you are awake? What is happening in your brain when you are awake? Just now you are awake. So what is happening? Your thalamus is active. How the thalamus is active? By some brain area which is a part of the reticular activating system area. All of you know reticular activating system. What is reticular activating system? They are nothing but multiple nucleus, and one of the important nucleus is the locus coeruleus and the raphe nucleus, and they are producing this norepinephrine and serotonin, and they are stimulating the thalamus, and the thalamus is stimulating the cerebral cortex. Now when will you sleep? Now when your cerebral cortex is active for long duration, when your cerebral cortex is active for long duration, what will happen? Your brain cell will accumulate metabolites. Simple. If you are studying for long duration and your brain is awake for long duration, what is going to happen? Your brain is going to produce more and more metabolite. One of this metabolite is adenosine. Important. And what this adenosine is going to do, if the adenosine level is very high, if the adenosine level is beyond a critical level, then adenosine is going to stimulate this anterior hypothalamus, and because we know that anterior hypothalamus is the sleep promoting area, the person will go for sleep. And whenever the person is sleeping, what will happen? Again this metabolite level will decrease, and whenever the metabolite level is decreased, the anterior hypothalamus stimulation will not be there, and whenever anterior hypothalamus stimulation is not there, the posterior hypothalamus will be automatically activated, and again the person will wake up from the morning, right? So this is the scenario which is known as the sleep physiology, that what is the basis of physiology of sleep induction and awakefulness. Getting my point? So this is in brief. Now look at, this is the theory which is known as the metabolite theory, but there are other theories also. What are the other theory? Other theory is that neurotransmitter theory. Genong is saying that obviously this above theory is true, but apart from that you have to remember certain neurotransmitter which are responsible for your induction of the sleep and wakefulness. Okay, how to interpret this? Look at these two things, wakefulness and your REM sleep. They are two extreme of one another. Wakefulness and your REM sleep, they are extreme of one another. Okay, what do you mean by that? Means when your norepinephrine and serotonin level is high, reticular system is not thalamus. I told you reticular system is consist of various nucleus which are below thalamus. The nucleus that I have shown, that the locus coeruleus, this raphe magnus, and there are multiple other nucleus also. They are part of the reticular activating system. Okay, and they are giving stimulation to the thalamus. They are not in the thalamus, right? So see here, so the locus coeruleus, I told you that locus coeruleus produces this norepinephrine, and serotonin is the raphe nucleus, raphe magnus. So these two nucleus, they are part of this reticular activating system. Okay, and there are various other nucleus also. So this nucleus, whenever they are producing huge amount of norepinephrine and serotonin, what they are going to do? They are going to maintain your wakefulness. They are going to maintain your wakefulness. That I want to say here. Okay, and in previous diagram also I have shown this thing, that serotonin is high, norepinephrine is high. Okay, what is going to happen? The person is going to remain awake. Along with that, whenever these two things are occurring, acetylcholine level will also be lower, right? But whenever this thing is happening opposite manner, what is the opposite one? Norepinephrine level is decreased, serotonin level is decreased, and your acetylcholine level is high. Just opposite to this. Look at here, look carefully. So just opposite to this. So everything is controlled by this reticular activating system. It is written here. Okay, so what will happen? The person will enter into the REM sleep stage. So if I ask you that, tell me one most important neurotransmitter for REM sleep, one most important neurotransmitter for REM sleep, your answer will be this one. Your answer will be this one, acetylcholine. Acetylcholine must be higher. Acetylcholine must be higher in your brain. Along with that, obviously norepinephrine and serotonin has to be lesser, and that will produce your REM sleep onset. So what about non-REM sleep then? What about non-REM sleep then? We know that non-REM to REM can conversion occur, but for non-REM sleep to occur, you require this neurotransmitter. These are the main neurotransmitter for non-REM sleep. What is that? There should be increased GABA, that is the inhibitory neurotransmitter, and there should be less amount of histamine in your brain. So please remember, histamine is a substance which maintain your wakefulness. Okay, when the histamine level is less and GABA level is very very high, then the person is going to enter into the non-REM sleep stage. Non-REM sleep stage. But when the acetylcholine level is high and your norepinephrine serotonin level is less, then the person is entering into the REM sleep stage. Okay, so obviously when the GABA is less and histamine is high, the person will remain in the awakefulness stage. So this is the whole neurotransmitter theory of this sleep cycle. I hope everybody understood this thing. Now tell me whether you understood this thing or not. Okay, whether you understood this thing or not, tell me whether you understood. You have to remember this neurotransmitter theory. Okay, along with that, all of you know that recently orexin. So orexin is a substance which produced from the lateral hypothalamus. Orexin is a substance which is produced from the lateral hypothalamus, and it causes switching between this wakefulness to REM sleep stage. Okay, wakefulness to REM sleep stage. So this orexin is responsible for switching between. So when the orexin level is high, the person will maintain the wakefulness, and when the orexin level is less, the person will enter into the REM sleep stage. So this is orexin, you also have to remember. So now look at what was your MCQ. What was your MCQ? Your MCQ was here. Wakefulness to non-REM sleep stage. Wakefulness to non-REM sleep stage. Okay. Sleep, and does this leads to an increase or decrease in thalamocortical activity? Now you tell me the answer correctly. Now you tell me the answer correctly. I'll wait. Wakefulness to non-REM sleep stage. Exactly. So wakefulness to non-REM sleep stage. Tell me, what is the answer now? Non-REM sleep. What neurotransmitter do you require? There should be high GABA, and that should be, tell me, which is the answer? You are entering into wakefulness to non-REM sleep stage. Non-REM sleep entry means you require huge amount of GABA, you require lesser amount of histamine, and because of this, what will happen? Your thalamocortical activity will be decreased, and that's why D is the correct answer. Good. That's why D is the correct answer. Very good. Thank you so much. Thank you all of you. Now you got the gist of it. Okay, so please don't forget this metabolite theory. This is very easy way to explain your sleep cycle, and this is the neurotransmitter theory. This is the neurotransmitter theory, which is also important. This is given in Genome, and previous one I have taken from research article. Now this is the same type of question, but here the question is, look at the question, read the question, but you will understand that the question is similar to the above question. Just I have put to ask you answer. So the history is given that restlessness during the night, okay, and they are asking non-REM to REM sleep, right? So what will be the answer? So here the REM sleep they are asking. REM sleep, just now I told you, for the REM sleep what you require? You require increase in acetylcholine. So find out. So increase acetylcholine is here also, increase acetylcholine is here also, increase acetylcholine is here also. So there will be answer between A, B and C. Now look at, so there along with the increase acetylcholine, exactly, give me the answer everybody. There should be the decreased level of, exactly, very good, a decreased level of serotonin will be there, decreased level of norepinephrine will be there. So this is the answer of the question here. Please remember these two. No B, decrease in norepinephrine and increase in histamine. No, increase in histamine means this is leads to wakefulness. This will leads to wakefulness, increase in histamine. So this is not the answer. B is not the answer. C is the correct answer. Now in the above MCQ, so look at these two MCQs are similar, almost similar to one another. So previous MCQ we have seen here that here they are asking about the non-REM. That's why you have answered D. But here C answer, look at here, an increase in GABA and melatonin. Why this melatonin is not the answer? If I say, sir, histamine is not there, but why melatonin and GABA, an increase in GABA is not the answer? Always remember, this melatonin is responsible for maintaining the circadian rhythm of sleep. It is responsible for maintenance of circadian rhythm of sleep. Okay, that is not for wakefulness or sleep induction. It is for maintaining of the circadian rhythm of sleep. That is a 24-hour sleep cycle that is maintained by one of the factor is the melatonin, but it is not for induction of the sleep. Okay, maintenance of the sleep or your circadian rhythm maintenance is responsible for melatonin. Now, even if the question is non-REM to REM or wakefulness to REM, answer will be the same to same. Okay, Dr. Ram, your answer is whether it is non-REM to REM or from wakefulness to REM. The answer is same, that you require huge amount of acetylcholine and you require decreased amount of norepinephrine and serotonin. That's why this arrow is put here also. The arrow is put here also and the arrow is put here also, that from this. Okay, so this is the thing. What not possible? Okay, so decrease in norepinephrine, increase in, okay, ये तो answer हो गया. So what we have understood here? We have understood here that you are asking, sir, if wakefulness to non-REM, if the question is wakefulness to non-REM, obviously wakefulness to non-REM means you require acetylcholine for non-REM sleep. Okay, so for induction or for starting of REM sleep, you require acetylcholine. Okay, and you require decreased amount of norepinephrine, you require decreased amount of serotonin. This is the thing. Now from wakefulness to REM, if you look at the sleep cycle, that is directly not possible, but possible in some pathological state, like for example, you know, the narcolepsy, that is possible. The patient directly enter from the wakefulness stage to the REM sleep stage, and that's why there is severe loss of muscle tone. Okay, and that is nothing but your narcolepsy. Okay, so physiologically it is not possible, but it is possible due to certain disorder, like for narcolepsy. Okay, because of that the person lost the muscle tone completely, because in non-REM sleep, REM sleep stage, the muscle tone is lost completely, right? So that is the thing. Okay, now whatever we have understood here, I have written here completely, that awake stage means there will be increase in norepinephrine, increase in serotonin, and there will be reduced level of acetylcholine, right? Along with that, there will be reduced GABA and increase histamine. So this is the thing which is occurring during awakefulness. Then from awakefulness, the person is entering into the non-REM sleep stage. What will happen? You require increased amount of GABA and reduced amount of histamine. But from this non-REM sleep stage, when the person is entering into the REM sleep stage, you require the reverse of the above. Reverse of the above means you require this. Acetylcholine levels should be higher and norepinephrine, serotonin levels should be increased, right? Decreased. That is the thing that you have to remember. But always remember, when the person first enter into the sleep stage, he must have to enter into the non-REM sleep stage 1. Okay, then he will enter into the REM sleep stage, and then again he will enter into the wakefulness stage, or like this. Okay, this is the sleep cycle basically. Okay, so please remember this neurotransmitter model. So someone asked me that what are the different disorders. So this is the disorder list of disorders, sleep disorder, that I have kept here. That non-REM sleep disorder is this, that the sleep waking, sleep talking, bruxism, nocturnal enuresis and night terror, all of them are the non-REM sleep disorder. Okay, and I have written the stage also, that in which stage this disorder are occurring, in which stage this disorder are occurring. So bruxism is stage 2 mainly, nocturnal enuresis all stage can happen, night terror, okay, transition from stage 3 to stage 4. And look at the REM sleep disorder, narcolepsy. That's why I was telling that narcolepsy means the patient directly enter from the wakefulness stage to the REM sleep stage, and because of which there will be severe loss of muscle tone, right? And that is nothing but one of the feature of narcolepsy. Along with that, nightmare also occur during this REM sleep stage. ठीक है? Got it, everybody? Everybody clear? Just give me a thumbs up whether you understood this or not. Right? Okay. So now the last question. Not getting any response from you. There is so much lag. Okay, Dr. Ram. Sleep paralysis in REM 2. That's, I told you that sleep paralysis REM में ही होता है. Okay. Very good. Now the last question. So this is a recent AIMS entrance examination question. Look at, in physiology Viva, examiner asked the student who recorded first human EEG. That is Hans Berger. Who recorded first human EEG? Hans Berger, right? And the student replied, I don't know. Examiner felt bad. He gave him a hint. So this is the clue here. That the name rhymes with that of the things which you get in McDonald's. Then the student gave the right answer. And this is typical of priming. It is not associated learning. It is not associated learning. Okay. So please remember what is priming. So this is the typical example of priming. This is the typical example of priming. So look at here. Fill in the missing word. Fill in the missing word. So you can easily answer. Tell me what is the answer. Red, blue, orange, yellow. What is the answer here? Tell me the answer. And look at the here. Give me the answer. Plum, nectarine, pear, apple. Okay. What is the answer here? Answer here. Give the answer of this quiz. What is in front of you? Red, blue, orange, yellow. Okay. So whenever I am giving this clue that you have to, yes, so you have to fill in the blanks with name of a color. So here this is nothing but green. But here also GR is given. Okay. But you are not saying green here, because here are the clue that it should be a name of a fruit, and that is nothing but a grape. Very good, my dear. So whenever I am giving this kind of hint, okay, whenever I am giving this kind of hint or clue, this is typical of priming. But what is associative learning? Associative learning, the basis is the pairing. The basis is the pairing. Okay. So please remember the associative learning. What is the difference? Pairing should be there. What is the pairing? So if you give food, listen carefully. If you give food to an animal, the animal is salivating. Okay, the dog is salivating. So what is this kind of response? This response is known as the innate response. Innate response. This is innate reflex or innate response. No condition has been done. If I give food to you also, you are going to salivate. And you have not learned this thing from your parents, that whenever the food is given, you should salivate. Who's taught you? No. There is a hardware system in your brain, and because of the hardware system, you know that food means the salivation will occur, and that's an innate response. Now, if you give only bail to this dog, he is not salivating. No salivation is going on. Now you are connecting these two stimuli. Now you are getting pairing between these two stimuli. What is the pairing? So you are giving bail, followed by you are giving food. So you have given bail for the first time. Then after giving bail, you are presenting food to the animal. This is known as pairing between two stimuli. Always remember, pairing should be first the bail, followed by food should be there. Food, if it is coming first, and if the bail is coming second, then the pairing is not going to happen. Please remember that if you give food to the animal first, he has already started salivation. If you give bail after that, the dog will be unsatisfied that what you are doing here, just allow me to take my food. So then pairing is not going to happen. But whenever you are giving bail first and then food, then the animal is learning a association. The animal is learning an association between these two stimuli, that whenever the bail is there, I am getting my food. Association. And after this association is complete, after this pairing is complete, the condition has developed The condition has developed. What condition has developed? Now the animal learned that whenever the bell is ringing, I am going to get my food, and in anticipation he has started salivation. So even although the food is not there, only bell is there, dog has started salivation. What is this typical thing? This typical thing is nothing but the classical conditioning. Classical conditioning is an example of associated learning. So that's why in the above example I told you like this, that suppose your internal examiner has already taught you that student, learn this thing, that whenever I will say MACD, you are going to look at your burger, you will imagine the burger, and whenever you are imagining burger, you are going to give answer that Hans Burger is the answer. So now the student is learning the relationship between these two stimuli, that MACD means burger, burger means burger, Hans Burger will be the answer. If you teach this thing to student, multiple times, so teacher is teaching this thing to student multiple times, so then what is happening? The pairing is going on, and when the pairing has completely developed, and then when the external examiner is giving a hint that MACD, immediately you are giving answer Hans Burger, then this is known as the associative learning. So what is the basis of associative learning? The pairing must be done beforehand, otherwise it is not a part of associative learning. That's why this associative learning cannot be the answer here. Here only the hint is the clue, and hint means this is nothing but my priming. Getting my point? I hope all of you understood this thing. So thank you so much for listening the thing. So whether you understood this now, okay? So now this is just for promotion that in Unacademy one batch course is starting from 11th of July, okay, and it will continue up to 27th of December. So in this batch course all of the subject will be taught, and I am there to teach you physiology. Physiology will be taught under two heading, that is the crash course on physiology. In this session within 24 hours I am going to cover up the whole physiology, right? After that the MCQ session will be start. So if you are interested in joining this course, please use my please use my code, that is the DRSOUMEN 10, okay? I'll be happy to assist you in physiology, and these are the list of all of your course detail and all of your teacher detail, and this is the way how to subscribe. All of you know that if you join for only 1 month, you are your subscription price will be 4,500, and you will get 10% discount above that, right? And within this 1 month you can watch unlimited subject, unlimited topic, okay? There is no limitation because it's a subscription. Subscription means you can access any of the subject within that 1 month, okay? The subject which has been covered up, the subject which has been already recorded in the Unacademy Learner app, you can also listen that, okay? So means if you are joining for 1 month, and if you have planned that you are going to finish the physiology from me and you are going to finish the pathology from all of them, then you listen all of them within 1 month. No one is preventing you from that. But for subscription, if you are planning to get subscription, please use my code, that is DRSOUMEN10. It will give you 10% discount, and this is various link how you can find me, and these are the various upcoming session which are completely free in Unacademy platform. You can attend those session from the Unacademy Learner app, right? So thank you so much for joining the session. Thank you so much. Okay, thank you Dr. Partha, great teaching sir, very useful session. Thank you so much. Okay, so now I am ending the session. Thank you, take care, stay safe.